remains a major challenge. So that's why also, in terms of diagnosis, we need to intensify research. And that we need the development of rapid diagnostics, or better diagnostics, better than expert. And we need the development of new drugs. We're still using the same drugs we've had for 40 or 50 years, and now we're getting drug-resistant TB. These are the challenges for TB overall. And this is just to highlight some of the funding gap. This is a slide from Mario Rubignani, who's director of the Global TB Program, and just showing the gaps that there are in terms of funding implementation and in terms of funding for research. And these funding gaps should not only have to be focused on getting the international community to address this, this is also trying to get our own national governments, where TB is common, to recognise that TB is important in the population and needing to invest in TB. It tends to be, as I say, neglected. It's a disease of the poorer and more marginalised populations. In terms of investing in TB, and I just want to emphasise this, The Economist, at the time of developing the Sustainable Development Goals, which is for 2016 onwards to 2030, and I'll come to those in a minute, did a quick analysis of what were the no-brainers to invest in. What were the things that you could spend money in and would give you your best return on your investment in terms of global development and wealth. And the number one in terms of infection is reducing tuberculosis. And they've calculated that for every dollar spent on tuberculosis, you will get $40 in return. Such is the cost of tuberculosis in terms of taking people out of work, long areas of treatment, making people sick, deaf, etc. If you can treat TB, cure people, detect TB, and spend money on that, you will get a big return on your investment. So even when you want to put it into dry economics, it's very clearly a positive thing to do. Even more so than reducing malaria. So now we have the Sustainable Development Goals, and this has come at a similar time as to the new WHO TB strategy. Now TB is at risk of getting a little bit lost, but at least now, unlike the Millennium Development Goals, it's been named specifically ending the epidemics of AIDS, tuberculosis and malaria. But it's only within one specific Sustainable Development Goal. These are very, very ambitious targets, as you know. So the language is changing, and we're not talking now about TB control, we're talking about ending the epidemic. So this is the global ambition, very, very ambitious. And so we're not talking about TB control programs as much as public health as it's important, but patient-centred care, focusing on every individual to get the best possible care, and recognising the inequity that's associated with TB, the catastrophic consequences for families, when the person has the breadwinner, becomes sick, etc., dealing with issues of equity and social justice, trying to get new tools, new policies. Once we get them, move them quickly into the field, rather than years of discussion and policy, etc., and recognising that we have to move out of the silo that is very much TB control programs and TB control, to reach out to other sectors and other health sectors, even beyond health sectors, to engage everybody in this aim. And the NTB strategy was approved, it was developed, was approved by the World Health Assembly in 2014. So the history of TB control goes a little bit like this. Before 1994 there really wasn't, it was just everybody for themselves doing what they would. And then the Union developed a DOT strategy in the 80s, which then WHO adopted. This is directly observed therapy short course. It's not just about treatment supervision, it's a number of different things, including political commitment, establishing the right procurement systems, monitoring systems, but using standardized chemotherapy. There used to be lots of different combinations that were used in the past. This is standardizing the chemotherapy, and that was what's known as the DOT strategy. Now, in 2006, WHO decided they wanted to expand the focus, realizing that this was containing things but not turning things down. So the Stop TB strategy was of course included pursuing high quality dots, etc., but recognizing other challenges and the importance of health system strengthening, reaching out to communities with TB, people with TB, and engaging wider all care providers, and focusing a lot on vulnerable populations. Now, this is the first time any attention started to be given to children, because they were one of the vulnerable populations along with prisoners. So we had children and prisoners together in this one. And then this now is moving to the NTB strategy. And this certainly started to turn things around. But this is the NTB strategy, much more ambitious, with 3 main pillars: patient-centered care and prevention. Much bigger emphasis now on prevention than there was previously. Previously it was more on case finding and treatment. Now the potential of prevention is becoming much more of a focus. And needing to have bold policies and obviously supportive systems, and again, intensifying our research and innovation to get better diagnostics and new drugs and better treatment regimens. Very, very ambitious targets. You can see for the Sustainable Development Goal, reduction in numbers of TB deaths is the primary outcome measure. 90% end of NTB strategy, which is 5 years later, 95%. And reductions in TB incidence, and aiming for free treatment and free diagnosis for everybody. So, if we continue to do what we're doing now, if everybody continues to do what we're doing now, this is the line that we will continue to go down. Now you can see by 2035, you will be nowhere near your targets. Okay? What has to be achieved in order to reach these targets, these ambitious targets that have been set, is something like this. This is 1.5% per year. This is more around 5 to 10% per year. A much, much bigger decrease is going to be required. This type of fall has only ever been achieved once in the past, and that was in Western Europe after the Second World War. And they were able to achieve, because TB was very prevalent in the first half of the 20th century, in Europe, for example. After the Second War, with all the rapid development and investment, etc., they noticed a fall of that type of nature. So this is, and people would argue that it's as much to do with socio-economic development as it was to do with the introduction of new drugs in the 50s. But they definitely had, the new drugs obviously had a major role to play as well. So this is very, very ambitious. And as I said, we need a very large fall per year to achieve this. I emphasise again, we're going to need new tools. If we just use what we have still at the moment, it's highly unlikely that we will achieve this. You need new drugs, shorter regimens, and some of these things are now being developed, and some of the shorter regimens are part of research now. And more of this prevention, identifying those with latent infection and giving them preventive therapy to help them stop developing. Yeah. Any questions so far? Right. So there's your 3 main pillars that I've already mentioned. And all of this is underlined by government stewardship and accountability. The TB world is now reaching out much more to people in government, ministers of health, parliamentarians than ever before, to recognise and convince them the importance of investing in TB. And building a strong coalition of civil society communities is critical. Those communities where TB occurs. So now we move to children. So the language up until the beginning of this millennium, around 2000, was about neglect and about child TB under control, don't know, etc. And interestingly, Catherine Hsu, who did lots of work with preventive therapy in children in the States over 30 years, even in 1956, was talking about children continuing to be neglected. So the neglect of TB in children has been going for a long time. Where is child TB common? Well, child TB is common wherever TB is common. The challenge, of course, is how common is it in children? And that's a big challenge. But wherever you have lots of TB in the community, you'll have lots of TB in children. And often the same communities that have a lot of TB also have a demographic pattern where quite a large proportion of the population are actually children. And so that's, in the African countries, for example, it's not unusual to have, or in somewhere like Papua New Guinea, 40% of your population children. So that is also a factor as to how much TB there might be in children. And in those same countries, they may have a higher prevalence of HIV or severe malnutrition and other things that make children susceptible to developing TB if they've been infected. So you will definitely get the burden, particularly in the high burden countries. So for some years now we've been working to put child TB onto the global health agenda. And this started with a subgroup that was formed at the union offices in 2003. As I said, WHO started to recognise children as a vulnerable population. And the first international child TB meeting was as recent as 2011. And it wasn't until as recently as 2012 that WHO actually started to put estimates for the burden of TB in children. So that's really recent. Up until just 4 years ago, there was recognition. It was the first time there was any attempt to try and understand what the burden is in children. So you can see that this has been very recent. What we've also done is we've tried to put TB, we've tried to put children into the context of the TB control agenda. But we've also tried to put TB into the context of the child survival agenda, the maternal and child health context. Because there's very few countries in the world that do not prioritise maternal and child health as part of their national strategic plans of health. And people don't think of TB as being a major cause of morbidity and mortality in children, but it is. They think of pneumonia, diarrhea, malaria, malnutrition, and they are all very common, and of course, in many cases more common than TB, but TB is also important. And it's important in direct and indirect ways. You have children who develop pneumonia or TB meningitis, tuberculosis, but also pregnancy is also a risk time for tuberculosis. And mothers who develop TB, they have a much higher their infant is higher mortality, they have small for dates babies, they have preterm babies, and they themselves get sick and are unable to look after their babies. So there's a lot of consequences to the child if the mother develops tuberculosis. There's actually estimated to be around 9 million orphans globally, children who are lost a parent to tuberculosis. That has major health consequences for children. And then you've of course got what we keep talking about, the catastrophic economic costs. Tuberculosis leaves people poorer than they were, and that has impacts on their children and families. And there's an area there where we still don't have a very good handle, but we recognise adolescents to be a risk time for tuberculosis as well, and this is an area that is requiring further understanding and investigation. Just to show you some data, We reviewed recently studies from Africa, mainly Africa, no, weren't all from Africa, mainly Africa, where they actually looked at children with acute severe pneumonia. This is not children with chronic cough. This is children with acute severe pneumonia, fast breathing, chest withdrawing, sick, needing to be hospitalised. And they got through gastric aspirate or induced sputum, got sputum for culture, which is the gold standard for confirming that the child has tuberculosis. And you can see, putting all the studies together, when there was over 3,600 children with severe pneumonia who had sputum culture, 7.5% of them actually had culture-confirmed tuberculosis. So tuberculosis does present, particularly in young infants, as a severe pneumonia in tuberculosis endemic settings. And the mortality of those who had TB with severe pneumonia in some groups was actually quite high. In a study that we did recently with a Ph.D, a colleague of Rita's, and ours, Prof. Ph.D from ICDDRB in Bangladesh, looking at children with severe malnutrition, again, 7% microbiologically confirmed had tuberculosis, and 23% overall were diagnosed with tuberculosis. So TB does present in the context of severe pneumonia, malnutrition, which we know to be common causes of morbidity and mortality in children. So in my view, what we're trying to do with the child TB agenda is to emphasise that TB is not just important in sustainable development goal 3, but it also has relevance to the legal requirement. TB is the major cause of maternal mortality in HIV endemic Africa. HIV-infected women have high burden of TB in pregnancy and mortality. So when you come together as a group, okay, we want to focus on child TB, the first thing you usually do is produce a whole lot of guideline documents. And there's plenty of those that have been produced by the child TB subgroup. Documents on guidelines for management, documents on updating the dosages for the drugs, recording and reporting for children, etc. But then you want to move forward. And so what we did as a group was, and we reached out to colleagues, others in child health, such as UNICEF, was that we put together a roadmap, which was launched in 2013. And it's about, including the needs of children and adolescents in research, policy, clinical practice, getting better data for children, developing training and reference materials for healthcare workers. And this one's particularly important, getting national champions, local leadership, people who are enthusiastic and want to move things forward, working with their national program, people from child health who can engage with the program and help work forward on issues around child TB. Not missing critical opportunities for intervention such as preventive therapy. Engaging the key stakeholders, people in the child health community who don't normally think about the issues of TB children, addressing research gaps, getting the funding, etc., forming coalitions and partnerships. But one of the first steps in this is you have to know your epidemic. And this is a real challenge for TB in children. Because, as I keep going back to, we don't have a simple diagnostic test. So when we don't know how many children we're missing, and even when we diagnose children with TB and put them on treatment, we don't even know how many of them actually do have TB. And this is really quite a challenge. Okay, for adolescents it's easier because they have more like adult disease, and they will present and give you sputum, and it's much more similar to it is for adults. But we're talking here to young children. These are the ones most likely to get sickest and die of TB. And this is a challenge. WHO, in its most recent report, estimated that there's 1 million cases of TB each year in children, of the 9 million globally, so about 10% of the total caseload. Now, even this estimate is twice as high as the one they had in 2014. Why? It's because we've been giving it more attention. So the accuracy is getting better and better, and using modelling and other ways of looking at this. And so now, even since 2012, where it was around 300,000 cases per year, it's now being estimated that it's around 1 million cases. And this makes it's easier to get advocacy when you have more accurate numbers about what might be going on. So we think it's around 10%, which is what you will find if you actually look at specifically within countries, as we did in Malawi once, as has been done in Bhutan recently and other countries. In countries where TB is out of control, where there's a lot of transmission, and as I said, there's a large number of children in the population. And this is an example in Papua New Guinea. The percentage of TB that is children is close to a third, around 30%. And so it's much higher in very, very epidemic settings. The actual numbers that WHO have recorded is lower than the 1 million. And there's two main reasons for this. But there are more and more children being reported to the WHO. The MDR, we don't have any estimates. We just know that wherever MDR is common in the community, MDR will be common in children. That's where they get their TB from. And we know that from countries in Eastern Europe and Russia, there's a lot of MDR in children because there's a lot of MDR in adults. It's estimated that there may be around 32,000 MDR, but that's just from modelling 2010. Indonesia has a heavy burden of TB. A national prevalence survey was done in 2013-14, which found much higher numbers than was expected. And so the 2015 report, the data were revised, and the numbers from that prevalence survey informed these types of numbers. Very high prevalence of TB in Indonesia, high incidence, and after the prevalence survey it was recognised that probably perhaps as low as only 32% of the cases in Indonesia are actually being detected, are being diagnosed and treated. There's a lot of missed cases in the community. And these are the people who are out there still transmitting TB to others, including children. These are the types of cases. We now talk about bacteriologically confirmed rather than smear positive, because bacteriologically confirmed can mean smear positive or expert positive, and then clinically diagnosed and extracorporeal. And in under 15, the child population in Indonesia was recorded in 2015 report 7% of the total caseload. And a large funding gap for Indonesia. So that's the situation as reported recently. Right, I've run out of it. Go ahead. Something went on for a while. Okay. So in the WHO situation, excellent. What you're talking about is these are the cases known to the MTP. So this in Indonesia is the 33% that we know these people. But what's out there is those that are perhaps being diagnosed and treated but not reported to the MTP. Yeah, because the private sector or maybe even in the public sector, they're being diagnosed, they're being treated, but they're not actually reporting to the program. Or then there's a bigger group that are actually not yet detected or not yet diagnosed. So this is where the gaps can be. And we think for child TB, in some countries, this is the problem. I know, for example, one country, Laos, this is definitely the situation. They have a prevalence of TB similar to Indonesia, around 600 per 100,000, but they treat extremely small numbers of TB in children every year, even though the doctors at the hospital recognise that there's probably quite a lot of TB in children, they're not being treated. The because they expect the child to be bacteriologically confirmed. But that's really challenging. Most children will not be bacteriologically confirmed. 95% will not be bacteriologically confirmed. So if you have to have bacteriological confirmation, you're not going to treat the children with a clinical diagnosis, which is the majority. So that's a challenge in some countries. And then you have a situation where there's a lot of children being treated for TB, but they're not being reported to the program. And children are less likely to be reported to a program than adults, because children with TB present to the Child Health Services, not to the National TB Program Sputum Services. And most child health workers and paediatricians, particularly in the private sector, don't realise that they should be reporting every case to the program, even for children. It's mandatory in many countries, but it doesn't happen. To illustrate this, I just wanted to show some findings of a study done by Sassi Lestari, who I think maybe still is, or was at the time with University of Guatemala. Sassi? No. So what they did was that they went into hospitals in Java and did a cross-sectional study and went through the registers and looked to see how many children were being treated for TB. And I think this was around 2006, 7 or something, but anyway, I can't exactly remember. But they found in Java almost 5,000 cases of children who had been registered, who had been treated for TB, but only 1.6% had actually been registered in the program. So it's probably true that there's a lot more treatment of TB in children that is reported by the national programs, WHO, because there's a lot of children being treated, but they're not being reported. And just to give you a closer look at that, this is the numbers of child TB cases, inpatient and outpatient. And you can see that it's 22% of the total burden, not 7% as reported by the program, but for this group. 22% of all the cases in those settings were children. And the majority, as you'd expect, are under 5. A proportion are smear positive. And many of these children are being detected at non-teaching hospitals. So clinical diagnosis of TB in children takes experience and a certain skill, and we do a lot of training on that. And I think usually in teaching hospitals and tertiary centres, there's usually quite a lot of confidence about making the diagnosis of TB in children. But children don't present to tertiary hospitals with TB. They present to primary and secondary healthcare settings, and many of them are outpatients. TB doesn't always make you acutely sick. You just develop a chronic cough, you start losing weight. You don't need to be rushed into hospital to intensive care. You can slowly deteriorate, and particularly older children. And so we have to recognise that the group that we have to support is also primary and secondary healthcare centres that see sick children come to them as outpatients in helping make the diagnosis of TB. Very important slide for a number of reasons. So this is really just trying to tell you that if you, as a child, are infected with TB, somebody's coughed, you're in the same room, you've been infected, you've inhaled the Mycobacterium tuberculosis, and you're infected, what is the risk of you developing disease? Now, if you're already a healthy child going to primary school, and you get infected with TB, your risk of developing disease is actually quite low, because you have a healthy immune system, mature immune system, you're a healthy child, etc. But if you're young, particularly under 2, you actually have a very high risk of developing disease. And you have a high risk of developing disseminated disease, TB meningitis, biliary TB. So this is a particular high risk group for developing TB if you've been infected. And then the other group that goes up again, as I said before, is adolescents. For reasons we don't particularly understand. But, so this is important. Why is it important? Well, if you're looking at your data for child TB, you would expect most cases will normally be under 5 years of age in an endemic situation. But also, this group is particularly challenging in terms of getting samples for sputum, for example, but also have low numbers of bacilli. They're hard to get bacteriological confirmation. So this is a group that's very hard to get bacteriological confirmation of tuberculosis. This is also the focus of your preventive therapy because of the high risk. So BCG will reduce the size of this red bar by maybe 80%. BCG will reduce the risk of disseminated tuberculosis. But how do you reduce the risk of the other forms of TB? And one way you can do it is that if you have a parent or adult or grandparent with tuberculosis diagnosed, you look at their young children in the same household, the same family, and if they're sick, you can examine them for TB, but if they're not sick, you can give them preventive therapy, and you will reduce this risk by as much as around 80-90%. So this graph sort of illustrates many different things. We normally expect, therefore, most cases of TB will occur in young children if we're diagnosing accurately. If a child is infected with TB and develops TB, not all of them do. They're infected with Mycobacterium tuberculosis and they go on to develop TB. Not all of them do, but if they do, they'll usually do that within 1 year of being infected. So the history of contact is particularly important for what's happened in the last year, not what happened 5 years ago or before the child was even born. Most cases in children are pulmonary, and of course most will be smear negative or smear not done, but they are also at risk of dissemination, and so extrapulmonary is also common. The type depends on the age. So the young ones often get disseminated disease and TB meningitis. Older children, they get big lymph node disease, or pleural effusion, pericardial effusions, spinal TB, these sorts of things. The clinical challenges and diagnostic challenges. The ones most likely to die from TB, to get really sick and die from TB, are the young ones, or those that present with severe pneumonia, malnutrition, HIV, or MDR TB. And these are all the hardest groups to diagnose. So that's a really quite an important challenge. And as I said, diagnosis is particularly challenging for bacteriological confirmation in the young ones. And you have to also recognize that the symptoms of TB, cough, weight loss, those sort of symptoms are common in this age group anyway, because children are often getting respiratory tract infections, developing pneumonia, or having problems that fail to thrive because of nutritional issues and other things. So that's how TB presents, but so do many other challenges in this particular age group. And that's also what makes it very challenging, yeah. So we talk a lot about rapid development of diagnostics. The rapid development of diagnostics for pediatric TB happened at the end of the 19th century. We had a decade up to 1896 of development of new tools, and we really had very little since that period of time. These are the tools that we still use largely. Clinical, X-ray, bacteriological when we can, and tuberculin has a role as well. All of these have limitations. So history is important. A symptomatic child, if the child doesn't have any symptoms, it's highly unlikely that they have TB. So you really got to be symptomatic to have TB. So that's a negative predictor. But Tuberculosis, it doesn't tell you whether the child has TB disease, it just tells you the child's been infected with TB. Chest x-ray, very low specificity. Very low specificity. And can even be normal in children with TB. So it has even problems of sensitivity, but very low specificity. And our problem, as I say, for bacteriology, such as smear or even expert, for children, is low sensitivity. So we're left with these challenges, and we're left with the whole problem of usually making a clinical diagnosis. Expert, is everyone familiar with what I mean when I say expert? Expert is a real-time PCR, get the sputum, put it in the machine, 2 hours later, it'll tell you whether they've detected Mycobacterium tuberculosis and whether or not it has rifampicin resistance. Okay? So it's definitely an improvement upon smear, and in children, it's 3 times more sensitive than smear. But it's still not fully sensitive. Compared to culture, 2/3, 66%. Highly specific. Highly specific. And it gives a result that's much more rapid than culture. We get a result within 1 to 2 days versus culture, which is weeks. And it also, if you suspect the child has MDR TB, this is particularly important to do expert because you can get data on rifampicin resistance. There is a new expert ultra, which is hopefully going to be similar in sensitivity to culture, which is being introduced this year. Has had accuracy tests done, and it's definitely more sensitive than the expert we're using now. So there are some improvements. But always in children, the challenge is to get a good sample in young children. That's really the big challenge. Gastric lavage, induced sputum, these sorts of things. Just trying to put it into some sort of comparison to adults. Adults, if all of these people here had TB, these adults, smear will pick up around towards a half of them. Expert will improve that up towards 2/3. Culture will take it even further. And then you'll still be left with some where you require a clinical diagnosis. The problem in children is that even culture is only around 30-40% perhaps sensitive. So expert is better than smear, but it's not as good as culture. And at the moment, we think that expert's about 20% sensitive. So 80% of children with TB will not be positive for expert. You cannot rule out TB with a negative expert. So that's not a great test either for children. And what we need is more information about research on implementation to inform the optimal usage of expert in children. And there is more and more of that type of work being done, but that's definitely required. This is one example from the field, some studies conducted by Fine, using an expert in the programmatic conditions. The diagnostic yield was twice as high as smear microscopy. Large numbers of children with presumptive TB, over 1,000 diagnosed, and they, of these, 30% resistant. So, of all the children who provided samples for expert, 8.5% were expert positive. So that's what it is in the programmatic conditions. So clearly you can't use it to rule out TB, but they did detect children with rifampicin resistance who needed MDR treatment by using the expert. One thing that's also true is that if you're doing it in outpatients, you'll get a lower yield than inpatients. Because outpatients aren't as sick, often their TB is a bit earlier than the one who's really sick and already in hospital. So they don't have as many bacteria, and so you tend to have a lower yield. Same if you do it in children in contact screening, active case finding. If you have a child who's in early stages of TB, it's less likely you'll get bacteriological confirmation. So what we really want is, this is expert looking for the bugs. What we want is the biomarker, the blood, if we possibly can. And there is research being done on this type of thing, such as work done at the University of Melbourne, by Mark DeBrucker, who's completed his Ph.D. and was able to find markers in the blood that can help distinguish between infection, or not having any infection, and disease. And that's the sort of things that, but we're a long, long way away from that. But that's the hope for the future. In the meantime, we rely on these sorts of tools to try and help health workers who are not well trained in child TB to be able to support the management of TB in children. And this is something that we developed in the union, something by the Sentinel project. Treatment-wise, in recent times, the dosages for children have been revised and have been increased compared to before 2010. This was on the basis of pharmacokinetic data, particularly in young children under 5, that said if you use the same dosages as adults, milligrams per kilogram, your blood levels will be very low, particularly in the young children. These are the ones at greatest risk of death. So we decided to increase, WHO decided to increase the dosages for children back to where they were often in the 1960s originally anyway. So no risks of toxicity, particularly by increasing the dosages, but trying to get high levels in children. This caused all sorts of confusion for the programs because there was fixed dose combination available for children, did not suit these dosages. And I can happily report that in December 2015, there's the launch of a new fixed dose combination for young children under 25 kilos that has this sort of combination. And this is as a dispersible, it's a tablet that can be dropped into liquid and then disperses and they can just drink it. So you don't have to carry syrups around, you can take home tablets, but then give it as a liquid formulation. And the average treatment cost will be around $15 for the whole 6-month course. So that's a much more affordable treatment course as well. And this is something that is now being, other dispersibles are being developed for use in children. And this is something that we're now focusing a lot on and trying to roll out into programs. So this is a new development for children, and it's a positive one. And this is a weight band where you can use this up to 25 kilograms, for example, fairly easily. Finally, on prevention, there are numbers of different ways of preventing TB in children. The first is to improve TB control in the whole population. If you can reduce the burden of TB in the community, you'll reduce the burden of TB in children. So the first is to find those cases with smear-positive disease or whatever, get them onto treatment and cure them. That's improved case finding and management. The second is BCG. As I've mentioned before, BCG is particularly active in preventing TB meningitis and disseminated TB, not so effective in preventing pulmonary TB when given to newborns. So its main proven benefit for neonatal BCG, protection against severe forms. But then there's contact screening and management. Widely recommended for young children in households with TB, universally recommended but rarely happens. But this is an important area. Contact screening and management is not just for the provision of preventive therapy, it's also for case finding for TB in children who already are sick and need to be diagnosed. We'll come back to that a little bit later, but I know that Asante has done a study on in Nepal, looking at different ways of screening for TB in children. And I think I'm right in saying that your conclusion was that household contact screening was the best way for case finding children. And then, of course, there's infection control. You don't want children hanging around health facilities with exposure to TB. Again, WHO is now having a big focus on preventive therapy and screening, close contacts. These are extremely ambitious targets because we're almost starting at ground zero. At the moment, this is less than 5%, and they're hoping to get up to 90% or more. Same here, this is less than 5%. Most children are not actually screened in practice in most of the TB endemic countries. So this is very, very ambitious. But, as I say now, focus on trying to do better with preventive therapy and screening. To give you an idea of the potential, and Rita and I commented on this particular study from Uganda, because it was well done. and it also shows the sort of things that you might find. Going into households where there are children of TB cases, half of the children being under 5, they were able to find 7% of child contacts had bacteriologically confirmed TB. That's a high yield. So they identified 79 children with TB that had not yet been diagnosed. And this particularly was more common in the young children. Extremely high prevalence of TB in these young child contacts. Also, in those that didn't have TB or active disease, they put 483 onto preventive therapy and only 2 developed TB. And that would normally be closer to 5 to 10%, here it's less than 1%. So it demonstrated a number of different things. The high yield from active case finding in households, children who already have TB, and the role of preventive therapy. The evidence is already there. There's been evidence for decades. Some of the first randomized controlled trials ever done in human medicine were preventive therapy in children in the United States, preventing TB meningitis in children who have had positive skin tests. The evidence has been there for a long, long time. The problem is making it happen and addressing the huge policy practice gap. And there are all sorts of barriers that we recognise about for implementation of preventive therapy. And some of it's really also, the difficulties, if it's done at a facility, only done at Dr. Sajida Hospital, but not done at the Puskas, it's very difficult for families to bring it's just not going to happen. And if you need to have a skin test or a chest x-ray on every child contact, it's not going to happen. You haven't got the tuberculin, chest x-rays are expensive, hard to get, particularly with all children. So there's all sorts of issues of where you should implement. The health workers also don't have a very good understanding as to what the role of preventive therapy is. And it's difficult for a health worker to explain to a family that your healthy 2-year-old child needs to have medicine every day for 6 months. People find that very difficult to understand, and I would as well as a parent. So it takes time to implement because it's a difficult issue in terms of conception. And for similar reasons, adherence is a challenge, and there are various costs. These are some of the things that Reggie's looked at, but I'm not going to, I wanted to finish now. In 2006, understanding some of the barriers of trying to implement this in a resource-limited setting, in the first WHO guidelines on child TB, we introduced a symptom-based screening approach. So all you have to know is, what is the age of the contact? And are they well, or are they sick? And if they're sick, they need to go and be evaluated for TB disease. But if they're well, they don't have to go anywhere. They can stay at home. But you need to start, if they're under 5 and they're in contact with skin positive, they need to start preventive therapy. And this can be done at the Puskas level, in the community. If they evaluate for TB disease and they need treatment, of course they can be treated for TB, supported back in the community. If they don't have TB disease and they're under 5, they can go back on preventive therapy. And then it's a different approach for those who are over 5 years or more. Because unless you're HIV infected, currently in many countries, you don't use preventive therapy for this group because the risk is lower of them developing TB than this group. But in a country like Australia, where there's a lot more resources, they use preventive therapy for all of it, even including the older children. Because it still has a role, but in a more resource-limited setting, you tend to focus on this group. So it's just one of those arbitrary decisions in terms of risk-benefit ratio that in public health that is made. Now this may change with time, but at the moment, the child contacts who recommended for preventive therapy are those under 5 who are well, and those HIV infected of any age who do not have TB disease, and they can have preventive therapy. So what Rita did here in Yogyakarta was enroll a bunch of children who were contacts of TB cases. Some of them were under 5, some of them were over 5, assessed them. Some were symptomatic, majority were well. Of those that were symptomatic, some of them actually ended up on TB treatment, including one child with TB meningitis who had not yet been diagnosed. So it was early diagnosis that had a good outcome. So 21 of the 269, that's around 8%, actually had disease at the time of screening, TB disease. The rest went on to preventive therapy if they were either well or didn't have TB disease. And then followed them up for 12 months. None of these under 5 developed TB by 12 months. Remember, that's the time you normally develop TB after exposure. 4 of those over 5 did develop TB disease. And probably the reason for this being 0 is because these groups received preventive therapy. Even though they're a high-risk group, received preventive therapy. So it's just a nice illustration of evaluating the symptom-based screening approach. If we're going to implement preventive therapy more widely, we need as national programs and others to develop monitoring and evaluation tools to measure what we're doing. As we go, we wanted these types of how many screened, how many diagnosed with TB, how many eligible for preventive therapy, and then how many of those actually receive preventive therapy, how many completed that type of tools. So there's more and more work being done to standardise this in our national program. More programs are developing IPT registers or preventive therapy registers, etc., and screening tools. And there's, as I say, more and more of this happening. And we have implemented the community-based screening for some years now with a project in Vietnam, and that included improving community awareness and developing pamphlets, posters, etc., to understand the rationale. And you can see there from screening in Vietnam, for example, eligible for IPT from the screening. Not every family accepts IPT, some say refuse, so 2/3 of the families accepted it. But of those that are actually taking it, quite high completion rates. And that this is all being done in the community by the community health worker, who's the same person as the treatment supporter for the case of TB. So you don't have, this is how it's being managed. And that's the way I think it has to be done, decentralised, community-based. There are sorry for this busy slide, but there are shorter regimens that at the moment, the recommended one is usually 6 months of isoniazid preventive therapy every day, but there are shorter regimens that have been shown to be equally effective, including one, which is now used in the US, where you have weekly isoniazid rifapentine for just 3 months. So it only takes 12 dosages. This compares to 270 dosages for 6 months of IPT. So I don't think we're too far away from shorter, simpler regimens for preventive therapy, which will make implementation much, much easier. And there are shorter regimens already being routinely used, and we know that the toxicity of these new regimens is lower even than isoniazid. So there's hope for that in the not too distant future. We don't have guidelines on how to manage MDR-TB contacts for children, though there has been some work to show that fluoroquinolones are effective in preventing TB in these children, such as levofloxacin. There's been some work on that. And at the end of the day, whatever we do and try and implement, it's always going to involve some level of training, operational research, and implementation. And so, as I say, we've developed job aids, training toolkits to go with the guidelines. These are all freely available. And a very nice online training that can be done for healthcare workers, freely available online on the union website under what's called the Child to Be portal. Just to try and sort of get around the need for endless workshops of training. People can have access freely to these sorts of tools, improving in training. In terms of the roadmap, my final message. This is the lady who performed those first randomized controlled trials of isoniazid preventive therapy and showing its effectiveness back in the 1950s. And in 1961, she said there's many contributions which the pediatrician or child health worker can make to a TB control program. And the first thing we have to overcome is the negativism around child TB. And this is still relevant all these 65 years later. A very, very important message. 55 years later. And so a lot of what we're doing is about forming child TB working groups. Child health practitioners, paediatricians, paediatric societies, working with the national program, as Rena and others have been doing here in Indonesia, because there's many areas in which we can work together to improve data, improve management, do operational research, etc. This is a sort of framework that I put together just around those particular issues. So that's my summary. I'm aware of time issues. I'm sorry for going over time, but I hope I've given you a broad overview of some of the issues with child TB. Thank you.
Still have 25 minutes for questions. If you have any questions, please.
Yes.
Here in Massachusetts, we have a lot of cases of children with pregnancy. How do you think about the risk of tuberculosis infection in children with pregnancy?
So, the children with malignancy would be at risk if they're on chemotherapy, for example, or at risk of developing disease if they've been infected. They're not at risk of infection unless they're put into a ward with other people with TB or unless they have TB at home. So those children with malignancy will be a very big risk group for disease if they've already been infected. So I'm not sure whether you screen the children with malignancy with a tuberculin test before you start chemo. But no? Okay. So if you're concerned about the risk of them developing TB with malignancy while being treated, you could screen them, for example, with tuberculin before they have chemotherapy, and if positive, give them preventive therapy.
Is it possible to have reactions such as allergy reaction to this malignancy?
Yes, once they're on chemotherapy, yes, definitely they'll have an allergic reaction. That's why I think if you wanted to screen them for TB, you want to know, do they have any TB contacts? If they don't, you may want to screen them for infection. You need to do that before you start chemotherapy.
We see from the epidemiology here in Indonesia with like the balance of is it still possible that children with pregnancy have
of course it's possible. The tuberculin test is not 100%. It's about 80% in a healthy child will be positive. No, for young children, I think TST either way you can choose. Both have their problems. They're not perfect tests.
Excuse me.
What can we do for minimize misdiagnosis, over or underdiagnosis in case of childhood TB?
Yeah, I think there's no easy answer. I think it's training. Yeah. I mean, there's many diagnoses that I think are very straightforward. It's not always difficult. If I know that the mother has severe positive TB and the baby's weight is doing this and the baby's starting to cough, I have no problem. I'm going to start that child's TB treatment. The problem is often when there's no history of contact and you think the child might have TB because they have some of the symptoms. Now, one thing that I stress, I see overdiagnosis of lymph node TB because people feel the lymph nodes. Feeling for lymph nodes, that's not TB. You will feel lymph nodes in young children because they've had tonsillitis or whatever. It's big lymph nodes that you can see as they walk in the door. You have to teach health workers, how does lymph node TB present? It presents as big visible lymph nodes that are there for months that don't go away. Yeah, not painful, etc. What about TB, pulmonary TB? If a child walks in, has had a cough, 1 week, 2 weeks, not getting better, I'm not sure, no history of contact, or the weight's just faltering a bit, I'm not sure, no history of contact, and the child's not that sick, tell them to go away and come back in 2 weeks. We don't use the follow-up and things like that enough. Because if that child has TB, when they come back, they will be getting worse. Yeah? But most children will actually get better with their cough or other things. So I think we have to learn from experience and teach and learn from each other. We should have more about teaching of health workers around TB in children, when they're training as nurses, when they're training as doctors, when they're training. It's very important because we're relying on clinical skills most of the time.
In remote areas.
So there's no easy answer.
In case of an adult condition, what will you choose to? It's better to do underdiagnosed or overdiagnosed for TB in children. So, I mean, you just the first.
I guess if we start to give more attention to TB in children, we will move from underdiagnosis to overdiagnosis. There's no doubt about that. But yeah, I mean, that's a challenge. There's no easy answer there. I will say that the treatment, if a child has TB and they get put on treatment, one is that outcome is very good, better than adults, and also they have less toxicity of the drugs than adults, so they tolerate the treatment very well. So at least that's for first line drugs.
As you have said, that diagnosis and treatment of childhood TB is already communicated in the test. So how about in case of children who are infected with HIV and childhood TB? How are there any strategies to improve diagnosis and treatment of?
Okay, so if you're in a HIV endemic setting or you suspect HIV in the family, you should test every child with query TB for HIV. Yeah. So at least that's one test that is sensitive and specific. You want to establish first if that child is HIV infected. If the child's HIV infected and you think might have TB, your diagnostic approach is exactly the same. There's no difference really in the way that they present, etc. It's just more difficult because children with HIV also have chronic respiratory infections for other reasons. Lymph nodes, they often have lymph nodes here, but that's not the lymph nodes of TB. Having symmetrical lymphadenopathy, as the children with HIV do when they have LAP and other things, that's not TB lymph nodes. TB lymph nodes is in usually one area, big, swollen, etc. It's a different presentation.
No, I think it's, you can use the experience